The cardiovascular system, in a model that is easy to understand, is a hydraulic system. It is based on fluids moving around, and as they say in Game of Thrones, if you cause the water to fall out of the man, he ends. So we have three components to this cardiovascular system. We've got a pump, a tank, and pipes. The pipes are the blood vessels that carry fluids around. They come in two major phases. There are arteries, which carry blood away from the heart, and there are veins which carry blood back to the heart. It is not oxygenated or deoxygenated. It's whether you're going to the heart or away from the heart that determines whether you are an artery or a vein. When you talk about the pulmonary circulation, whether it's oxygenated or deoxygenated flips. Okay, that's why it's important to keep that straight. The tank is the actual blood volume itself. It is the amount of fluid that you fill those pipes with. Everybody has a specific amount of fluid, and we're going to talk about that in a second. Okay? When you lose a critical portion of that fluid, usually about 60%, you are irrecoverably hypovolemic and you're going to die despite having some of that fluid remaining. And then there's the pump, which is the heart driving all of this through the system under pressure. The pump itself consists of return vessels, the superior vena cava and the inferior vena cava, both returning to this chamber right here, and we are going to go around the room and we are going to name the portions of the heart beginning right here. So the blood returns to the right atrium, and then from the right atrium passes through the tricuspid valve to the right ventricle, and from the right ventricle passes out the pulmonary artery. Now note that this is an artery that carries deoxygenated blood. Okay? It's an artery because it's leaving the heart. It goes to the left atrium. Not quite yet. Where do we go in the pulmonary artery? In the lungs, that's right. So we shoot out to the lungs via these vessels right here. We pick up all of our oxygen. Now we are oxygenated blood, and from the lungs come the pulmonary veins. The pulmonary veins then return to the, now you can say it, and from the left atrium, they go through the mitral valve. The mitral valve then leads to the main pumping chamber of the heart. If you lose this chamber, it's game over. And that chamber is the left ventricle. That's right. And the left ventricle, under extremely high pressure, pushes that blood out into the major blood vessel of the body, which is the aorta. The aorta. Very good. So this is the circulatory system. The first three branches of the aorta, the first two of those three, rather, go to the brain, and that's why it's so easy to have a stroke. Anything that gets involved in your circulatory system, anything that shoots air or clot or whatever into the cardiac circulation is going to end up with its first two stops being your brain. Now, the pipes. We talked about the chambers. The tank is what I want to focus on right now. So when you talk about blood, the blood volume is dependent on your gender and your mass, and those two factors contribute the vast majority of the determination of the amount of blood that you carry. Okay? Women carry less than men by a reasonable fraction, a little more than 10% difference. And you carry less and less blood per kilogram as you get heavier and heavier. Okay? Capacitance vessels are what we refer to as blood vessels that are able to distend to take on extra volume. These are things that can flatten. Okay? These are primarily veins. Capacitance vessels are designed to allow us to have more fluid or less fluid in our body without immediately having to pee out any excess and without seeing circulatory collapse if we run too low. Okay? Now, the blood vessels in the body follow a specific pattern. You have the aorta, which is the prime artery. The aorta then goes to the arteries. The arteries go to the arterioles. Okay, now the arterioles are extremely important. Arterioles are the primary muscular portion of the blood vessels, and they regulate the blood pressure. So when we talk about vasoconstriction, when we talk about clamping down those blood vessels, what we are affecting is primarily the arterioles. We are clamping down on that portion of the arterial circulation. The vessels that are larger than the arterioles are what we refer to as elastic arteries. Their job is to serve as a pressure reservoir, okay? Why was the crossbow an effective weapon? Why did the crossbow change warfare? You had strong men who could pull a bow and release it, right? Some of those bows that they used to use, those long bows, had 100-pound drawstrings. You ever tried drawing a 100-pound bow? I can't do it. The crossbow was different because you could take a crank and store up a bunch of energy in the crossbow, more than any man could ever draw back. And then it'd catch on a notch and you could release it all at once. The same is true of the circulatory system. The heart charges the aorta. That is the heart's primary purpose. It is to charge the aorta. So you pump up the aorta, which is a large elastic blood vessel, to a very high pressure, and the aorta is, if you are healthy, elastic. So at that point, it's like a balloon that you blew a bunch of air into. When you let that balloon go, you're going to get a steady, progressive flow of air out of that balloon. Does that make sense? If the heart had to push the blood all the way through your entire body all at once, it would have to be 10 times stronger than it actually is. What it does is it charges up the aorta, and then it allows that blood to circulate over a much longer period of time, okay? It's conservation of energy. So instead of pushing all at once, it does it over a longer period of time. Same thing as a ramp. I could either pick up a 100-pound weight and drop it on this thing, or I could slowly move a 100-pound weight up a ramp. Either one's going to accomplish the same goal, right? Conservation of energy. So once we pass the arterioles, then we are ready for the capillary network, okay? The capillary network is the primary source of gas exchange in the body, okay? All tissues need to be within 3 to 7 cells of the nearest capillary. If they're not, tissue generally cannot survive. There's a reason there's a massive gap in organism size between microcellular organisms and complex organisms with a circulatory system. It's because once you get larger than that certain critical size, you have to have some way to circulate the oxygen around, right? Now, the capillaries are an inefficient network. They have a leakage rate of 3%, and that leakage is what we refer to as lymph fluid. Okay? That's free filtered water, sometimes with microprotein, that is trapped in the interstitial tissues of the body. That has to be collected because it is constantly accumulating. That's where the lymphatic system kicks in. It picks up that extra fluid, and under the force of muscular contraction, calf muscles, thigh muscles, arm muscles, pec muscles, that fluid is passively forced back into the heart. Okay? From the capillaries, we begin the vein system. We begin with venules, okay? These are teeny tiny little veins. They don't serve much purpose other than capacitance. Then we begin the large veins. These are the ones that you're sticking IVs into. And then come the cavae, all right? 3/4 of the body's blood flow comes back via the superior vena cava, the upper extremity collection system. The remainder comes from the inferior vena cava. Big thing about the inferior vena cava, it obligately passes through the liver. That's where all of that metabolism comes from, and that's why first pass metabolism that you're going to hear about with drugs is a thing, because it has to pass through the liver. Once you get through the cavae, you're back in the right atrium, the cycle starts all over again. Clear? As mud. Don't worry. They're recording it. We can review as we need. So what is shock? Shock is anything that prevents the completion of this process that I just described to you, okay? It is anything that causes a mismatch between the amount of blood your body requires and the amount of blood your body is circulating. So, there are multiple forms of shock. Number 1, cardiogenic shock. That means that all the other parts are working fine, but the heart can't do it. The heart lacks the energy necessary to appropriately charge the aorta to deliver that blood pressure. Okay? This can be for a variety of reasons. We will cover them. Obstructive shock. That means the heart wants to do it, but something is physically plugging up the outflow of the heart. Okay? Something is physically blocking the heart from being able to charge the aorta. Distributive shock, that means that the heart is adequately charging the aorta, but all the other blood vessels in the body are wide open. So that aorta just dumps its pressure immediately. It's like taking a balloon and instead of letting it get its air out through the little neck, you just cut the entire neck off the balloon. Whew, air's gone in half a second. Hypovolemic shock. This means you simply do not have enough blood to go around, okay? You have got 5 loaves and 2 fishes and you are not Jesus. There is not enough to go around and fill up everybody's needs, okay? Hypovolemic shock. Highly desirable for the enemy, highly undesirable for your teammates, okay? So, consequences of decreased perfusion are multitude. So let's start at the back. Name a consequence of decreased perfusion. When the body is not getting adequate blood, tell me something that's going to happen.
Cell death occurs.
Cell death occurs. Where primarily? Where's the #1 spot? Open question.
Brain.
Brain's first. What's second? Not heart. Gut. Gut is hypersensitive to blood flow. Lactic acidosis will begin building up very quickly, primarily from gut necrosis in that setting. Okay. Another consequence. Confusion, again, the brain tissue is exceptionally sensitive to its blood flow. It has a very specific metabolism, and even very short interruptions in the blood flow to the brain can result in disruptions of that metabolism. The brain has a mechanism called autoregulation. That means that within a certain set of boundaries, the brain will automatically regulate its blood flow so that it gets what it needs, okay? That's why you can have a blood pressure of 160 and think clearly and a blood pressure of 80 and think clearly. But that mechanism fails at both ends. At the high end, it lets through pressure that shouldn't be there. Pew! Things rupture. That usually starts at 200 and becomes a major problem at 250. And below about 80, that autoregulation mechanism falls way off and the brain can no longer keep its forward perfusion going. Okay, and then we talked about lactic acidosis. This is what is referred to as livido. This is inadequate perfusion of the skin. This is those arterioles clamping off, trying desperately to keep blood going to the brain, the heart, and the guts. Okay, so when you are in trouble, your body will secrete epinephrine and norepinephrine, and it will constrict those arterioles the same way Levophed does or epinephrine does, and you will see the skin become cold. You will see slow capillary refill times. You will see a decrease in color and an increase in pallor with the patient, okay? That is a sign that they are vasoconstricting. Okay, the neuroendocrine response is what the body does once it realizes this is happening. Now, the body is really dumb, really, really dumb. Like you can't even imagine how dumb about understanding whether you're in trouble or not. It's only got 3 sensors. That's it. Number 1, carotid baroreceptors. Okay, there's little stretch sensors in your neck arteries that are supposed to pulse every time you have circulation. But if your pressure is very low, they will not pulse as intensely. Okay? Number 2, you have aortic arch receptors that can tell whether that aorta is being adequately charged. And number 3, and most importantly, are the afferent renal arterioles. Okay? They can tell whether the pressure going into the kidney is as expected or below expected. Now here's the key. We did not used to live beyond 40 on any regular basis, okay? On an evolutionary timeline, it is a brand new phenomenon that human beings could experience most of these forms of shock from anything other than being eaten by some other animal. Are you with me? So, the body has not come up with better sensors and it has not come up with better reflexes in the 200 years that we've actually been able to live longer than 40 years old. So if any of these sensors are telling your body, my blood pressure is low, your body has only one assumption that it's going to make, and that is that you just had your leg bitten off by a saber-toothed tiger. Okay? And here's what's going to happen. It is going to activate 2 responses, an immediate response and a delayed response. The immediate response is over here on the right. The norepinephrine and epinephrine release, this is your fight or flight chemicals, okay? This is going to result in vasoconstriction. This is endogenous vasopressors, okay? This is going to squeeze all of your skin, and it's going to squeeze your muscles. It's going to squeeze your peripheral circulation to try and push blood flow back to your heart, your brain, okay? It's doing this because it thinks you've lost blood. It's trying to make the most with what it assumes is left. But then comes round two. Those sensors in the kidney that we talked about are going to trigger something called the RAS cascade, or the renin-angiotensin-aldosterone axis, okay? Now in this process, what's going to happen is the kidney is going to start by secreting a chemical called renin, which is then going to make its way across multiple organs, create a chemical called angiotensin, which will then be converted in the lungs to angiotensin II, and then that will then subsequently lead to the creation of aldosterone. All of these chemicals accomplish the same two purposes. Number one, body hold on to salt. In the human body, water follows salt. I'll say it again, water follows salt. You want more water in your body, you want more salt. You drink all the tap water you want, you're just going to pee it away because your body's prime directive is to maintain a single osmotic state. When you're drunk and you're hungover and you're feeling terrible, grape Pedialyte, ice cold, brand name only. Take it from a pro. This is the stuff that has enough salt in it that that fluid will actually be retained, and it's nearly as good as intravenous saline at rehydrating you. Okay, same idea. So this will lead to vasoconstriction primarily through renin and angiotensin, and water retention primarily through angiotensin and aldosterone. All right, so far so good? Immediate reaction, delayed reaction. Now the key here is, like I said, the body is dumb, really dumb. If the heart is weak because you've had a bunch of heart attacks, nature doesn't know about heart attacks. Heart attacks do not occur in dogs. They don't, okay? That mechanism did not evolve for us to deal with heart attacks, all right? So if your heart's suddenly squeezing a third as well as it should, your blood pressure, your ability to charge the aorta is going to go down by 2/3, right? Body doesn't know that the problem starts here. Body thinks the problem is you don't have enough fluid, period. So what's it going to do? It's going to hold on to way too much fluid, right? You just gave the guy 2 liters of saline in the ambulance. Body doesn't know that. All it knows is those renal arteries aren't seeing very much perfusion. So even though you just gave them 2 liters, they're still firing all their chemicals saying, hold on to that fluid, hold on to that fluid. For God's sake, hold on to the fluid. Do not let it go. All right. Cardiogenic shock is what we just began touching on. This is where the pump is not as strong as we want it to be. Okay? This is where the ability to charge the aorta is inherently weak. This can occur from congestive heart failure. The majority of congestive heart failure comes from myocardial infarctions, about 50% of it. The other 50% of heart failure is what we call non-ischemic cardiomyopathy. And that is from viral illnesses, chronic hypertension, familial diseases, genetic predisposition to late development of muscle weakness. Okay? Ventricular aneurysm is a consequence of a myocardial infarction. That's where a wall has already mostly died off, and there's only enough muscle left that it bows out, it just sags out, right? So stress creates congestive heart failure. So you can get something called a Takotsubo cardiomyopathy if a person is genetically predisposed to have this and they experience an event with a profound exposure to adrenaline, okay? Battlefield shock, unexpected death of a family member. I saw one person have it once because they'd flunked their SATs where they were expecting to completely knock it out of the park, right? If you get this massive adrenaline surge and you're predisposed, you will develop heart failure just from toxicity of that adrenaline on the heart, okay? It has a very characteristic shape on echocardiogram for the majority of those patients. Only the tip of the heart balloons out. It's really weird. It makes a big bulb just going ribbit, ribbit, kind of like a frog's throat, kind of crazy. Takotsubo is Japanese for octopus trap, I think, and that's sort of what it's named after, is the shape of these like round little octopus traps they use in Japan. Stress in the setting of sepsis is also directly toxic to the heart, okay? I am utterly uninterested in hearing that a patient has an EF of 20% as measured by echo 10 minutes after their cardiac arrest. Could not care less. I'd be more impressed if they don't have an EF of 20% right after a cardiac arrest, right? It's like you sleep on your arm. Your arm going to feel good for the first 5 minutes after you get off it? No! It takes a while for these things to recover, right? So, when you're in sepsis, again, direct toxicity can cause low heart squeeze and requires treatment. There's a reason that dobutamine was real hot for a while in the treatment of sepsis. It's much less prevalent in the algorithms now. Post-cardiac arrest, we just talked about. You stun the heart. It's going to take the heart a little while to recover. Okay. Heart failure, this is a useless diagram that doesn't do anything to help you. This is a diagram that just repeats what we've already told you, but it has a very pretty picture over here of a heart that's barely moving. These walls are, I mean, not even discernibly squeezing. That's about as bad as any echocardiogram is ever going to look. I hope your heart never looks like that. If it does, please come see me. We will fix you. All right. Right heart failure is a very special form of heart failure. Listen to me very carefully because you will see this material again. Right heart failure shows all of the signs of congestive heart failure but has clear lungs. Right heart failure shows all of the signs of congestive heart failure but you have clear lungs. So when you're thinking about heart failure, the way to think about it is where is the problem? Think of it like a highway. There's a wreck somewhere and the traffic is going to back up behind that wreck, okay? If the left ventricle fails, that's where the wreck is. So what comes before the left ventricle? The left atrium. What comes before the left atrium? The lungs. What comes before the lungs? The right ventricle. So guess what the #1 cause of right heart failure is? It's left heart failure. Let me repeat that again. The #1 cause of right heart failure is left heart failure. It's just traffic backing up down the interstate, okay? But in right heart failure, the wreck is in the right ventricle. The lungs are down the road. The lungs are nice and clear. Just like the road would be nice and clear if the wreck were here and you're over here. Does that make sense? So, when you see a patient, gentlemen, write this down, with jugular venous distension, chest pain or shortness of breath, lower extremity swelling, and orthopnea, which is an inability to lay down flat without feeling short of breath, your primary question is, what do the lungs sound like? Okay? If the lungs are wet, you diagnose left heart failure. If the lungs are dry as a bone with no crackles, you diagnose right heart failure. Okay? Why does this matter? Because right heart failure is critically volume dependent. Left heart failure is always volume overload. Okay? So in left heart failure, you're always taking away fluid. Less, less, less. Okay? Got to dry out those lungs. Got to keep those lungs from flooding. Okay? Does that make sense? In right heart failure, you have to be very careful. There's a right amount. If a patient with right heart failure is profoundly hypotensive, you push fluids on them while giving them medicines to flog that right ventricle. That's the D chemicals, dobutamine and dopamine, to get that right ventricle going. All right? So if a patient is having an acute heart attack, it's affecting their right ventricle, they need fluids. The right chamber has become passive. Okay? The right ventricle normally operates at pressures up to 40. The left ventricle normally operates at pressures up to 160. It's not even a comparison, okay? It's like me going to lift with you guys. Different ranks. Okay? Same idea. With the right ventricle, it's a weakling. When it becomes passive, you can actually jam enough fluid into the patient to force it through the right ventricle passively and still get some fluid to the lungs and the left ventricle. Okay. Heart failure treatment. Lasix is the hallmark of heart failure treatment. And it doesn't have to be Lasix. There's 3 chemicals plus a 4th bonus chemical in that field. So that's Lasix, which is furosemide. There's Bumex, which is bumetanide. There is Demodex, which is torsemide. Those are the 3 common ones. If you or your family ever need to be on heart failure medicine, use Bumex or torsemide. The reason why is that oral Lasix becomes unavailable to the body when you are really volume overloaded. The gut swells with edema, and the Lasix can't get across. So when you need it the most, Lasix works the least. IV Lasix obviously doesn't have that problem. It goes right into the bloodstream. But if you have a family member or you yourself need one of these diuretics, use torsemide or Bumex because they cross the gut easily even when there's a lot of edema. Okay? Now, over here, they've got chemicals to flog the heart. They've got milrinone, dobutamine. These are chemicals that take the heart and make it do more work than it wants to do. They are particularly useful in severe left heart failure, and the D chemicals, dopamine and dobutamine, are useful in right heart failure. All right, very good. They've got some nitro over here. The nitroglycerin is what we refer to as afterload reduction. So if we are trying to get fluid out of this pressure overloaded heart, right, we have to give it some place to go. All right? So if you are trying to motivate a soldier, you do not want to point him directly into the machine gun nests ahead. You will have a very difficult time motivating him to move towards the machine gun nest, right? So what you have to do is make it look much more appealing. And what you do is you lower the arterial blood pressure. So part of congestive heart failure treatment is you give them ACE inhibitors, you give them nitroprusside, you give them nitroglycerin, you give them things so that the area that the heart is trying to pump out to is under lower pressure and it's easier for that fluid to flow forward. It's counterintuitive, but it is effective. I think we're just animating through clips here of some sort. There we go. Right heart failure, we've already talked about. Right heart failure. Oh, I see. They're just putting up diagrams of all the things that don't make it like left heart failure. Yeah, okay, great. Obstructive shock. This is rare, okay? There's only a couple of ways to get this. Number one is a pulmonary embolism. This is particularly true of people wounded with catastrophic injury on the battlefield as pertains to you guys. You get a large femoral fracture. What type of embolism is it that you get that causes? There you go. Fat embolism, if you get a penetrating wound and the patient demonstrates sudden onset of shortness of breath, what type of embolism might that be? Air embolism, good. And then, of course, there's the one you're probably not going to see in any of the populations you guys are treating, which are pulmonary embolisms, unless they've been on a plane flight from Iraq all the way back to Colorado, okay? Pulmonary embolism, blood clot that ends up primarily starting in the legs, though it could start from anywhere on the right side, the venous side of the circulation, travels to the heart and lodges in the ventricles. The lungs are nature's filter. Okay? They are designed to suck up small clots and deal with them, all right? It's when you throw too large a clot at the lung that it can't handle it, right? Okay? Special forces are in a similar situation, right? You are trained to deal with all situations, and yet, if I put 100 people against you, it will not be sufficient that your squad is there, no matter how well trained you are. You will be outnumbered. The same thing is true of the lungs, okay? You can outnumber the lungs with sheer volume of clot, and that's usually when these people get in trouble. Okay, cardiac tamponade. This is primarily caused by pericardial effusion. This is something that can develop as a result of inflammation. So viral illness, patients have ST elevation all over their EKG, every territory. Every territory. You cannot infarct every territory of the heart at once. It's not possible. You'd be dead, right? So if there's ST elevation all over the EKG in every territory, what they probably have is pericarditis. Just like with any irritating problem, the body will respond by secreting fluid at it. Okay? You get a cut, you get a wound, it's going to secrete fluid. You nick yourself shaving, it's going to secrete fluid. Even after you stop the bleeding, it's still going to secrete that clear white fluid, right? Same idea. It'll do it around the heart. Where you will see this in battle is if you have a penetrating chest wound, you can get a tamponade from blood. Okay? If you lacerate the RV, the pericardium can serve as a one-way valve, and the blood can come out of the RV but not out of the pericardium. Patient will kill themselves because of this buildup of pressure. It's just like a constrictor python squeezing the heart to death. Pulmonary embolism, the symptoms are chest pain and dyspnea. Ironically, the chest pain is usually only with the very worst and the very best PEs, okay? So only the little bitty ones and the big giant ones. The ones in the middle do not hurt. They just cause profound shortness of breath. The reason why is because you get the chest pain from only 2 causes. Number one of those causes is for tiny little ones. It's that you've killed off a portion of lung tissue. It turns out it hurts to kill a portion of your body. For the big giant ones, it's because the RV is under such pressure overload that the RV itself is begging for mercy. It's going, ah, please, no more. Okay, it's on rep number 99, benching 200. It's not going to be great. The examination will demonstrate right heart failure signs. You will have tachycardia. You will have tachypnea. Will the JVD be up or down? Up. Yep, think of it like this. You've got a blockage in the highway, right? Where's the blockage? It's in the lung arteries and the pulmonary arteries, so everything's going to back up behind it, right? So you're going to get all these signs of right heart failure. Will you have pulmonary edema? Nope, because the blockage is in the pulmonary artery before you got to the lungs, right? So there won't be fluid backing up into the lungs. So this is going to look just like right heart failure. Okay, cardiac tamponade, we talked about this. Penetrating trauma, 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 and trauma. Okay, fantastic. So the key here is these things known as Beck's triad. They are rarely all seen in the same patient. Here's the key right here. Write this down. Muffled heart sounds plus shock equals cardiac tamponade until proven otherwise. Got it? If you can't hear their heart, you're listening with a stethoscope and you don't hear heart sounds, the reason why is probably because the heart is wrapped in a nice thick layer of water. Water transmits sound really well within itself and doesn't transmit sound out of itself at all, okay? All right. JVD, elevated, hypotension, sure, you're in shock, right? All of these are forms of shock. There are a couple of special signs. There's something called pulsus paradoxus, which means that when you take a deep breath and you load the right ventricle, the blood pressure that you measure in their arm or with an art line will go down. That's because in tamponade, there's only so much space. The chambers are in a zero-sum game, okay? For the right ventricle to be big, the left ventricle has to be small. So when you take that big, deep breath in, you fill up that right ventricle, there's no space for poor little left ventricle, so he can't pump very hard for the rest of the body, okay? That's not a normal reaction. Normally, the right ventricle and the left ventricle can both get big at the same time. All right. Electrical alternans, that means when you look at the EKG on one of the rhythm strips, it's big pulse, little pulse, big, well, I shouldn't say pulse, big QRS, little QRS, big QRS, little QRS, big QRS, little QRS. What that is the heart literally sloshing around in this big bag of fluid in the middle of the chest. All right. There are a couple of chronic causes. Hypothyroidism is one of them. The medicine minoxidil, if you take it orally, not the stuff you put on your hair. If you take oral minoxidil, it's very well known to cause that. Radiation causes that. Chronic kidney disease, only if it's really severe. That's called a uremic pericarditis. And cancer loves to cause fluid because cancer is extremely inflammatory. And as we said, anything inflammatory will cause the secretion of fluid. Let's move on to distributive shock. Distributive shock is almost always sepsis, okay? The only exception that you're going to see are these final 2 issues. Anaphylaxis, obviously you have a drug reaction. The body releases all of the chemicals from the mast cells, okay? Pew! Every mast cell just freaks out and dumps its chemicals, and the body's arterioles are overwhelmed, have no idea what to do. They completely wipe out, dilate as much as possible, and blood pressure goes, pew! What's the treatment for anaphylaxis? Epinephrine. Super concentrated epi or super diluted epi? Huh? 1 to 1,000, yeah, huh? You're gonna use the strong stuff there. And you inject that where? IV or IM? IM, that's right, do not inject at IV, you're gonna have a bad time. However, if they're crashing and burning and you need the pressure, you can give them a little bit, right? You can give them like 1 cc out of those 10 cc code syringes just to give them a boost while you wait for the IM to fix the real problem. Okay, neurogenic, this I hope you never have to see. This is where reflexes from the brainstem that help to regulate blood pressure have been catastrophically interrupted. Okay? This happens from cervical spinal trauma, usually at the mid-neck level or above. People who have this lead the most miserable lives you can imagine. They cannot get out of wheelchairs, they cannot get out of bed, there is no drug that can help them, there is no pacemaker I can implant that fixes this. This is a really terrible way to live. Let's hope nobody ever has to see that, okay? I've seen 3 cases of it so far, and if I don't see a 4th, I'll be perfectly fine with it. So then let's talk about sepsis. All right? Sepsis is where bacteria cause the body to develop a false reaction, where the chemical of the bacteria, particularly one known as endotoxin, okay, causes the body to lose the plot. At a moment when the body needs to be constricting the blood vessels to help fight the infection, this stuff says, don't worry about it. Don't worry about it. You just relax. You just take a little nap, okay? It's like a guy sitting in a car with the engine running in a closed garage, and you got someone next to him going, just relax. You're fine. Just breathe real deep, okay? Not a good idea. We want to actively fight this process, okay? The key to sepsis is to recognize the mismatch between blood pressure and skin temperature. Okay? If you have one clinical exam finding to hang your hat on, if you have a profoundly hypotensive patient from any mechanism other than sepsis, they should have cold, clammy extremities, because all of those vasoconstrictive reactions that we talked about earlier should be well underway. The body should be clamping down the skin, and the patient should feel ice cold in their extremities. Okay? If you touch the patient's skin and they are warm as can be, even though their blood pressure is low, then you have diagnosed sepsis until proven otherwise. It's one of the only ways that you can get this mismatch between blood flow and blood pressure, okay? Skin should be the first thing to lose blood flow once you start getting hypotensive. So sepsis then leads to all the things that we saw on the other slide, and we're going to move on. Anaphylaxis, we've talked about. Mast cell degranulation leads to vasodilation and leakiness of the blood vessels. If untreated, can result in catastrophic shock. The way you're going to recognize that is that the patient is going to develop swelling of all the things, okay? They are going to develop swelling of the throat, so they will, they are going to have hoarseness. They are going to swell in their face. They are going to begin complaining that they feel puffy. That's from retroorbital edema. And then you will see the swelling in the rest of their body. Okay? Don't miss the early signs and wait for this sign. This is someone who probably should have been treated about 30 minutes ago. All right? This is urticaria. This is patchiness of the skin, again, caused by that mast cell degranulation. You won't have to know that. Treatment right there, epinephrine, very good. Inject IM and support blood pressure while you wait for it to work. Okay? For added bonuses, you can throw some Benadryl in there if you want, but that is not considered the core treatment. Do not pick the Benadryl over the epinephrine on any test. Okay? Great. Neurogenic shock we talked about. Cervical trauma leads to loss of these sympathetic nervous system tones. Patients cannot maintain their blood pressure. The key here is that they have abnormal sympathetic reactions, okay? So they either have way too much or way too little sweating. Their blood vessels are either way too dilated or way too constricted. And this is key, they usually have wild swings between those two states. They can be sitting there perfectly cold and clammy 1 second, and then the next second completely drench the sheets. I mean, literally pour out 100 milliliters of water and sweat in 10 minutes after that. The treatment is you try to replace the chemicals that they have lost, the norepinephrine. You try to replace that. Doesn't work very well. They have a couple of drugs with names like droxidopa that try to help with that now by sympathizing with the norepinephrine receptors and mimicking that response. Still not great, okay? Of the 3 people that I've seen, 1 of them half responded to droxidopa and the other 2 are still wheelchair bound. Okay. Very good. Hypovolemic shock. Again, something you would like to induce in the enemy and avoid in your friends, okay? So, dehydration, fine. Obviously, if you don't take in water and you sweat it and breathe it all out, you will get hypovolemic. It is a tank. You can dry out the tank, okay? Blood loss, however, is the one that you have to deal with. So, the solution for all of this is replace whatever you're losing. okay? If the patient is dehydrated because they're homeless, they've been laying outside and it's a 98-degree day out, normal saline. Lactated ringers, take your pick. It depends on whether you ask a surgeon or an internal medicine doctor. All right, just put back the fluid. If the patient has blood loss, rapid transfusion protocol, let's go. Okay, someone's bleeding out in the operating room, hang a level 1 and start pumping it through. In the field, fantastic. Find a buddy and have him squeeze the bag. You got to get it going. All right, we're going to break now. Bio break, 5 minutes. Return here, please. Thank you, gentlemen, for your attention.